you're at the verge, believing or not believing on sacroiliac joint, I hope after this talk you will believe in sacroiliac joint as an entity, a disease as an entity, because that will make impact on your practice. Let's talk about it. We start treating sacroiliac joint long before we did spinal fusions. And this was known actually in the early 1900s as an entity, and we first in 1950s when we start doing PLIF, we quit doing sacroiliac joint fusion. And as a matter of fact, this is, go read the original paper, because that's really summarize it. If 100 patients with back pain come to you at any given time, 22% of them, the origin of the pain is not the spine, it's sacroiliac joint. But make no mistake, that means the rest of the 78% is the spine. Okay, so that doesn't absolve you to do the real job, to do your proper diagnostic. Now, I think the most important part is if they had a spinal fusion, especially L455S1, if they come back to you with back pain, 43% of that is sacroiliac joint, almost half. This is the half you cannot neglect, and this is the half that we often call it failed back syndrome, and this is the half that destroys your reputation. Patient has two problems. Often they have two problems. Yes, they're allowed to have two problems. You fix one, but patient's still in pain, same pain, and I will come back to that. And then they go out and say, the doctor did a surgery, but didn't fix me. I have still the same problem. So by you including this in your differential diagnosis, you're going to increase your practically healing of the entity you're dealing with, and it help the patient. Now, sacroiliac joint is a very complex joint. As a matter of fact, it is not a joint. There is a running joke when I go give these talks. I put a fresh $100 bill on a podium and I say, tell me the muscle that works directly on the sacroiliac joint. Anybody knows a muscle that works on both sides of the sacroiliac joint? No, there isn't. Sacroiliac joint, the muscle cross it, and sacroiliac joint is not a really joint, it's a remnant, and it literally only function it has during the birthing process, open up the pelvis about 3 to 4 degrees for the birth canal to get bigger. As a matter of fact, if it moves more than 4 degrees, it's considered pathologic. So I'm going to now show you a little anatomy of the sacroiliac joint before we talk about the treatment of it. And bear with me, I may go a little over the time, but this is worth it. Okay, this is going to have impact on your patient, on your practice. Now, the good news is most of the crucial structure in the sacroiliac joint are anterior. And here you see the so-called the posterior innervation of the sacroiliac joint. And what I want to tell you, because of this posterior innervation of the sacroiliac joint here, radiofrequency ablation overall is not very successful because there is a lot of variation and you cannot really get them. Now, here is another view of the sacroiliac joint, and you see the posterior elements are practically or virtually free of nerves. And that's why we started going posteriorly at that, and then we regretted that. Because when you go posteriorly, who has done, I mean, obviously some of you have done posterior true sacroiliac joint fusion. It's raise your arm if you have done that, because it's a very bloody surgery. It is, we do it only for trauma at this point. We never, I don't believe any reasonable surgeon would do that for degenerative or pain alone. Now, let's go back here. Now, the joint has two parts. Remember this part, the articular piece and the ligamental piece. And this is an actual sacroiliac joint. How many of you are ortho? More than half. Now, would you consider any regular joint anywhere in your body like this as a normal? No, this would be a completely arthritic joint. But this is a normal sacroiliac joint. And again, because it has no function, There's lots of variation, and again, you see the ligamental part here and the articular part. This is the remnant leftover of the cartilage. This is a normal sacroiliac joint. Now, what I want to show you with this piece that, you know, the typical patient for sacroiliac joint are female. After birthing process for 2 years, the rate is 7 times higher. They are in average 10 to 15 years younger. And more importantly, is that sometimes a trivial trauma can go on. In the night, often they tell me, my patient, that when they turn from side to side, the pain gets worse. Now, I'm going to now move forward and talk about what we call this joint. We call it chameleon joint because it can pretend to be L5S1 facet, L5S1 disc. It can pretend to be sacral insufficiency fracture. It can pretend to be even hip problem. It can present itself in many ways, but if you take one thing out of this talk, take this picture. Any kind of radiculopathy can be compatible with sacroiliac joint. Let me repeat, any kind of radiculopathic pattern pain can be compatible with sacroiliac joint. For a long time we didn't understand that, but now we know that because of the inflammation of the joint, the surrounding nerves can be very well affected by that, and this is a typical kind of pain you would see. Diagnostic is obviously, you know, let's start with the 14. You ask the patient, you have to touch the patient. That's a problem sometimes with us, okay? You ask the patient, stand up, please put your finger, your thumb, so there's no question, put your thumb on where the pain is, and if they do it twice, within an inch from sacroiliac joint, that's so-called 14 test. Now, there are lots of different kind of tests that you practically, it is a very strong joint. You use femur to provide significant amount of pressure on the sacroiliac joint, and because these tests are, you can look it up on my webpage, you don't have to memorize that. Because this joint is very strong, you have to put tremendous amount of pressure. You have to put the patient on a table and go really on the table, and that sort of prohibitively in a busy practice is going to really make your life harder. Now, I'm going to give you a hint. It's something that we are working to validate. We call that sacroiliac rapid combined test. May I demonstrate that test on you? So if for that, you're actually perfect. You keep it the way it was. Yeah, doesn't matter. Just put your ankle on your knee. Now, this is a starting point of that rapid test, okay? Somebody with sacroiliac joint has already problem doing that. But then, you know, you stabilize, you put the knee, ankle on the knee, you stabilize it here. With 3 push, and each time much harder, you go 1, 2, 3. And if that provokes a pain, then you know you absolutely have to include sacroiliac joint. It takes about a minute of your time, but then you can go do the other things because the other tests take more time. But then you can pass it on to a nurse or helper to do that test for you. And obviously I do it on both sides for so-called rapid test. Okay, so we are in the process of validating this test. So paper hopefully will come out. Bracing doesn't work, okay? Radiofrequency ablation is not very useful. It's not as good as in the spine for medial branch. Now the diagnostic, after the test, provocation test, the diagnostic is, these are the points. It has to be done by protocol. Low volume, meaning less 2 cc of injection of lidocaine or bupivacaine in the articular part of the joint with contrast confirmation. CT or X-ray or fluoroscope, low volume because you don't want to infiltrate everything, and you have to have a confirmation with the contrast, and 2 injections are considered diagnostic. I'm going to go 3 minutes above this because I think it's important to you to know that. But if you have 2 injections that give the patient 75% improvement, then you have a positive diagnosis of the sacroiliac joint. Now, it used to be in US 3 injection, but most of insurance now, they say 2 injection is enough because the result has been tremendous. Let me show you those results. This is the results. Now, let me explain this to you. They have two groups of patients who have done all the diagnostic and are positive confirmation of the sacroiliac joint disease. One, they continue conservative management. One, they do the surgery. And you see how it drops off. After 3 to 6 months, it was unethical to continue the control group. So they convert them all to treatment group, and look at that. They fall. This reflects exactly that. This, if that doesn't make you a believer, I don't know what it does, because this is the best amount of, and there are huge number of the patient in this. So this, please take a picture of this, because that really summarizes it for you all, okay? It was, it was unethical to continue the control group right there. So the idea is to make it stop. So I'm at 0, but let me tell you, open technique is out. Forget about it, except for trauma. The other technique is lateral to medial, and good news, if you don't go internally, nobody does, you only have to deal with the superior gluteal artery, and there are ways to avoid that. Now you have to understand the anatomy and x-rays. In the lateral, you have to make a true lateral of the pelvis with superior greater sciatic notch and ala of the sacrum aligned. Then you have two views, the so-called inlet view, which is a true axial view of the sacrum. Sacrum is the only bone you can get the axial view, by the way. And where you see here the pelvic floor, and then in the so-called outlet view, which is 60 to 65 degree against the inlet view, not 90 degree, because sacrum is not a flat thing, it's a wedge. Then you just have to put something that stabilizes it. Now we started with the thigh bone with the wedges. I didn't like it. The pull-out screw strength is not good. I went to different kind of screws. And at the end of the day, now I end up with the so-called trident. The trident, literally, it's 15-minute procedure. You put the first screw in, you don't have to go back and do the same processes, because once you have to put the first screw, the second and the third screw go through the screwdriver of the first screw, and that's in one procedure. So I draw the borders of the sacrum in the true lateral view, promontorium to the middle of the sciatic notch, where the entry point is. Here, the entry point is the middle of the sciatic notch, right here. You go at an angle perpendicular to the sacroiliac joint, not a true lateral to medial, perpendicular to the sacroiliac joint, and practically you put these screws in. We call it trident because you put the first screw in, then the second and the third screw go through the screwdriver of the first screw, and that makes an hour surgery a 15-minute procedure, because you don't have to constantly go lateral to medial. So I'm going to stop here. This is another picture of the trident and how it looked like. If I may, I can take 1 or 2 questions, but this is my presentation.
Thank you, sir. Any questions from the audience? Yeah.
Do you do any efforts to decorticate the joint and put in some graft or something?
One of the system I showed you has actually, it used to be called Zyga. It has a blade that would go in the sacroiliac joint itself. It would decorticate, and we would pack it and so on. It didn't give me any clinical advantages, so I quit doing that. What I do see here, if you look carefully, number one, this has a huge internal cavity. It has a lot of holes. It has something that cuts the bone and internalize it, but as well, what you may not see that the surface of these screws are sandblasted. They have the so-called pores that are 70 to 140 micrometer. That is exactly the size that we know bone grows into the implant. You guys have done PEEK, right? 10 years after you have done PEEK implant, you go there, you pick it up and pull it out. This 6 months later becomes part of the fusion and bone grows across. So I didn't have to do that since I'm using this kind of huge cavity and implant with the so-called micropore structure. But again, it has to be produced in a certain way. It has nothing to do with plastic or a metal and so on. It has to have the pores that are in the certain range, and this is not something you would feel. You cannot feel pores that are 70 to 140 micron. It feels smooth to you, but not to your osteoblast.